going to do axial, so starting first with the TMJ, okay? These two lectures today, they are not bad in terms of content. We don't have a ton of muscles, so it should be a little bit easier to get through this week, okay? So for the TMJ, just to review a little bit of your bony anatomy first, okay? This is your temporomandibular joint, also referred to as a TMJ. So making sure that you know your skull bones first, okay? We're not gonna go through all of these, but use these nice color-coded images to make sure you're able to identify them, okay? The specific ones that we are looking at for the TMJ are going to include your temporal bone, which is in purple on this picture, and then your mandible, which is in blue. So you can see where this articulation is with this little red circle. So your articulation between the temporal bone and the mandible, okay? So this is important because this is going to be probably your most frequently used joint in the body, okay? You use it for talking, for eating, for yawning, for chewing, all of those types of activities and movements. So you use it a lot, okay? So in terms of just the general structures surrounding the TMJ, we have the two bones that we already mentioned, okay, temporal bone, mandible. We have 4 ligaments that we're gonna go through, 4 muscles, and then just your joint capsule. Okay, there's also an articular disc that sits in here that we'll talk about as well. Okay, so your actual articulation. Okay, what bones did we say it was made of? Temporal bone and the mandible. Okay, so for the joint articulation for the TMJ, this is going to be the mandibular fossa of the temporal bone, which articulates with the mandibular condyle of the mandible. Okay, so those are your articulating surfaces, mandibular fossa and mandibular condyle. Okay, this is technically a modified hinge joint. Okay, it is a synovial joint. It is not a pure hinge joint because it does allow for some like gliding motion in there, which we'll talk through in a little bit. And then, like I said, right in the middle of this joint, you have an articular disc as well. Okay, so you can see the disc in this image here, how it sits right in between your mandibular fossa and your mandibular condyle. Okay, what's important about this shape is that this disc separates the joint into 2 different spaces, okay? So right here, you have an upper joint space, which is really the articulation between your mandibular fossa and the articular disc. And then right here, you have the lower joint space, which again is really the articulation between the mandibular condyle and the articular disc. Okay, now this is important because you can see you have different shapes here. So this is going to go back to our Pringle chip shape that we talked about with the thumb. So this disc accommodates the shape of the mandibular fossa as well as the mandibular condyle. So this is going to be important when it comes to our arthropneumatics, okay? Because we have both convex and concave surfaces here. Okay, so all in all, the disc helps to maintain the congruency of the joint as the TMJ is going through its different osteokinematic motions. Okay, it is very prone to dysfunction, to tears. That's when people get like the clicking or popping or locking in their joint. The articular disc is going to be the structure that is actually involved. Okay. All right, so for your ligaments, you can see them right here in this image. So 4 main ligaments that we're going to talk about. The first one is going to be the temporomandibular ligament. Okay, so this is what you're looking at right here. Again, for all of your ligaments, make sure you know anatomically where they're sitting, what bones they're connecting to, and then at least vaguely what their job is. Okay, so your temporomandibular ligament, like I said, it's right here. It's going to attach from the neck of the mandibular condyle and the disc, and then it's going to run superiorly toward the temporal bone. Okay, so mandibular condyle to temporal bone. Its job is to limit the mandible from excessive inferior, posterior, or lateral motion. Okay. Next, we have the sphenomandibular ligament. That is this one right here. So make sure you realize when you're looking at this picture, it has this kind of translucent appearance because it is sitting on the inside of the jaw, okay, or the inside of the mandible. So this is going to run from the sphenoid bone to kind of this middle surface of the ramus on the internal side of the mandible. Okay? Its main job is to limit excessive anterior translation of the mandible. Okay? And then the last one, it looks very similar, but now we're on the outside of the jaw. This is called the stylomandibular ligament. Okay? So this is going to run from the temporal bone to the inferior border of the ramus. Okay? On the temporal bone, it is technically going to start at the styloid process. So that's that big bony structure that sits right behind your ear. Easy to palpate. That's where this ligament starts. It goes all the way down to the inferior surface of the ramus. Okay? So again, since it's similar in position and shape to your sphenomandibular ligament, it is also going to limit excessive anterior mandibular translation. Okay? There's one more ligament here that we have to mention that you're not going to see in this picture, but it is called the stylohyoid ligament. Okay? It is going to run from the styloid process of the temporal bone to the hyoid bone. Okay? And its job is to basically just hold the hyoid in place. All right, TMJ osteokinematics, hopefully we know these by now, so let me see everybody depress their mandibles. TMJ elevation, lateral deviation, protrusion, retrusion. Any questions on those? Awesome. Okay, so one more thing to mention here, you do have a natural resting position of the jaw. Okay? That position is the lips are closed, but the teeth are not touching. So they're just sitting a couple millimeters apart, and then you're gonna let your tongue rest behind your two front teeth on the roof of your mouth. Okay? That is the resting position of the jaw where your muscles are the least engaged, where they're the least active. So if you have a patient that comes in with TMJ issues, that's always a good place to start, is teaching them that natural resting position where they're able to relax their surrounding musculature.
Did you say the resting position one more time?
So for the resting position, the lips are closed, so lips are touching. The teeth are not touching, so they're just sitting a couple millimeters apart. And then the tongue is sitting on the roof of the mouth behind the two front teeth. Good? Okay, so norms here are going to be a little bit different than what we've done previously, okay? We are not measuring these with a goniometer. You can do them with just like a little, like a paper tape measure. We have some in the lab downstairs, so we'll probably practice that in assessment next semester, okay? So alternatively, especially for depression, you can also measure by somebody's knuckles, okay? How many knuckles can they fit between their top and bottom teeth? That can also be an objective measure if you don't have paper tape measures, okay? But in general, your norm for depression is going to be 40 to 50 millimeters. Protrusion is 7 millimeters, and lateral deviation is 9 millimeters, okay? For depression, I know this isn't as good of an image as the other ones, but you would just literally measure from the top teeth, so the line right in between the top two teeth, top teeth to the bottom teeth, what that distance is. For protrusion, then for lateral deviation, you're doing it based on the lines between the central top teeth and the central bottom teeth. Okay? So again, you don't need to worry about those details for now, just memorize the numbers, and then we'll work on measuring them later. Okay? But for your, if you're using the knuckle method, you should be able to get 2 to 3 knuckles in between your teeth. Okay? Everybody go ahead and try it. See what you can get. Hand sanitize first. Okay, so this is, I'm gonna try to keep this as simple as possible. It is easy to get confused here, okay? So type this out clearly, write it clearly, or highlight it in your book, however you wanna do it, but make sure you spend time with this, make sure it makes sense to you, okay? So when we are looking at your convex and concave surfaces, okay, we're just gonna start there. So mandibular condyle, this portion right here, it's really easy to see that this is convex. Okay? Mandibular condyle is convex. The glenoid, the mandibular fossa is going to be concave. Okay? But like we said, we have these 2 different joint spaces that we're working within because we have this articular disc that sits in between them. So you have an upper joint space and you have a lower joint space. Okay? So the most consistent space in reference to what we have already learned thus far is going to be this bottom joint space. Okay, so we're going to start there first. So in the lower joint space, we have the convex mandibular condyle. Okay, so when this moves, this is your moving portion. So you're going to have convex on concave. So when you go, we're going to do mandibular depression first. It's easy to visualize it in this picture. When you go into mandibular depression, the ramus, this is going to be the bottom portion of your moving bone, the ramus is going to move posteriorly. Which means, since this is opposite, we know we're convex on concave, that your glide of the condyle is going to occur anteriorly. Anterior glide of the mandibular condyle. You also have a roll here, which would occur posteriorly. So lower joint space, mandibular condyle, convex on concave, anterior glide, posterior roll. Okay? Now, for your upper joint space, we are going to do this in reference to the disc. Okay? So your disc, all I want you guys to remember, your disc is going to move in the same direction as your glide from the lower space. So your disc is moving anteriorly. Correct. As it moves anteriorly, it's going to come down and forward underneath this portion of the fossa. So your articular eminence is what it's called. Okay, or articular tubercle is another name for it. Okay, so in your upper joint space, during mandibular depression, the articular disc is going to glide anteriorly. Okay, it's going to move forward and underneath that articular tubercle. So your disc moves the same direction as your glide. Okay, so all of this would be reversed if you were going into mandibular elevation opposed to depression. Okay, so with mandibular elevation, your condyle and your disc would glide posterior. TMJ elevation and depression are going to occur in the sagittal plane. are only going to move as one unit. Okay, so you don't need to think about the different spaces, none of that mental gymnastics. Okay, so there's only a glide here. You have no rotational component when it comes to protrusion and retrusion. Okay, so with protrusion, you have an anterior glide of the condyle and the disc. With retrusion, you have a posterior glide of the condyle and the disc. And this is occurring in the horizontal plane. Last one here is your lateral deviation. Okay, so again, this is a little bit different because we have two different things happening on each side. We're involving two joints. Okay, so for lateral deviation, this is also going to occur in the horizontal plane. Okay, this is a really good diagram to look at as you are learning this. Okay, so when we go into deviation, one side, you're gonna have a spin. Okay, that is going to occur counterclockwise. On the other side, we have a glide. Okay, so if we go into left lateral deviation, on the left side, your left TMJ, you are going to have a spin of the mandibular condyle going in a counterclockwise direction. And then on the right side, the right TMJ, you're going to have an anterior glide of the mandible.
So the spin will be on the side that you're going?
That you're deviating towards, correct?
Yeah.
So during left lateral deviation, on the left side, we have a spin of the mandibular condyle. It is going to spin in a counterclockwise direction. On the right side, we will have an anterior glide. Good? All right, moving on to our muscles of mastication. So these are the muscles that are responsible for all of your jaw movements. Okay, they're called this because they are involved in the chewing process. Okay, so we have 4 primary TMJ muscles. Okay, what are they called? Temporalis, masseter, medial and lateral pterygoids. Okay, so those are your 4 muscles of mastication. Temporalis and masseter are going to be your most superficial, and your zygomatic arch is going to be your dividing line in between them. Okay, so zygomatic arch right here, temporalis is going to sit on top. Below the zygomatic arch, your masseter is going to sit down below. Okay, and then if you look a little bit deeper over in this picture, you have your medial and your lateral pterygoids. Okay, medial pterygoid is going to be deep to lateral pterygoid. Okay, so again, for all of these, make sure you know your origins, insertions, actions, and nerves. Okay, the most important thing I can tell you guys for these is to make sure that you understand what is occurring unilaterally versus bilaterally, and in which direction if it is unilateral. Okay, do you understand what I say when I mean that? What I say when I mean that? Do you understand what I mean when I say that?
Mm-hmm.
Okay, so for example, your temporalis muscle. Who knows actions for temporalis?
Elevation.
Bilateral elevation and retrusion. What does it do unilaterally? Unilateral, ipsilateral, lateral deviation, okay? I know it's a mouthful. I know it's a mouthful, but you have to include all of those terms when you describe the actions because they all mean something, okay? So unilaterally is the action occurring to the same side or to the opposite side?
Same thing.
Okay, but that's what you need to understand when you're going through these cards, okay? Because for lateral deviation, temporalis and masseter both do unilateral ipsilateral deviation. So they both deviate to the same side versus medial and lateral pterygoids do unilateral contralateral lateral deviation. Okay, so they deviate to the opposite side. So if I am going into left lateral deviation, that means that my left side, temporalis and masseter, are contracting, and my right side, medial and lateral pterygoids are contracting. So all four of them are working together to perform the same action. Okay? So when it comes to your test questions, it's going to be more applicable like that versus, okay, what is the action of this one muscle? I'm going to give you an action, and that you're going to tell me which muscle we're working. Okay, so it can get really confusing. So if you start the studying up front, knowing that, make sure that you memorize exactly as the cards say. It will make more sense when it gets to those clinical type questions. Okay, does that make sense? Mm-hmm. Okay. All right, so otherwise, just make sure you hit on your origins, insertions, actions, and nerves for all of those muscles. Okay? Nerve is easy because they're all innervated by the same thing. Okay? Innervated by the mandibular branch of the trigeminal nerve. This is cranial nerve 5. Okay, you need to know it both ways, the actual name as well as the cranial nerve number in Roman numerals. Okay, so you can see, let's see. We'll go through all of that later, but just know that that is the branch that you are using for now. Okay. Now, there is one important pathology to talk about with this nerve, and that is called trigeminal neuralgia. Okay? So typically this is going to occur if there's some type of prolonged compression or irritation of cranial nerve 5. Okay? And this can either cause episodic or constant symptoms, but this is going to be their pain distribution. You have all of these different branches of the nerve that go through the face, and they're typically very sharp shooting pains that will result from compression on this nerve. So this is usually a pretty painful thing that people can experience. Okay. All right, muscles of facial expression. So I am not going to ask you guys to memorize your origins, insertions, actions, and nerves for every single one of these facial muscles. Okay? But I do want you to know the names of them and their basic actions. Okay? And we'll just keep it like that. Nice and simple. Okay? Last one here, one more important thing to point out for this section. There is another pathology that is called Bell's palsy. This is actually affected by cranial nerve 7. Okay? This is the facial nerve. And this condition causes a temporary paralysis that occurs unilaterally as a result of compression on this nerve. Okay? So with this, you can see in this image here, this is how somebody would present with it. So they're going to typically have kind of a drooping mouth, sagging eyelid. Their eye might be dry. They could have drooling down the face. Sometimes they're not even able to close their eyelid.
What happened?
Did you really?
Yes.
Tell us more.
First off, I thought I was having a stroke.
I'm sure you
So,
did.
the day before, my eye was watering really bad, just one side. And I was like, that's weird. So the next day, I dropped my kids off at school, and my husband looked at me, he was like, I don't think it's me, because his eyes were really bad. He's like, but y'all, your eyes are blinking at different times. And I was like, no, they're not. And he was like, yeah. And I was like, okay, well, I'm just going to smile for you. And he was like, that's weird. Your side of your face looks really funny. And I was like, let me just hold my arms up. And he was like, they're not drooping. I was like, it's not a stroke. I was like,
We're okay.
I'm convinced I was having a stroke. And so I get to the doctor and he was like, yeah, it's gonna get worse. And I was like, oh, fun. He was like, it's Bell's palsy, but you know, you're gonna have to tape your eye shut. That's what you're gonna have to do. Wear an eye patch. And so, all of that is true. If I didn't like turn my head to the side and drink something, I had no ability to close my mouth. So, it still is like, it's not 100%. I didn't go and do rehab for it. He was like, it's either gonna come back 100% or it's not. And so one side of my eye is smaller than the other one because of that. But yeah, I was more angry about my eyes were constantly dry. You cannot blink. And then I had to forcefully blink. And then when I would tape it closed, it was so irritating. I could handle the pulling and all of that, but it was my eyes that froze me nuts. And it was caused by stress.
It was caused by stress. I was gonna say, if you know what the underlying mechanism was.
Yeah, and it puts you at a higher risk for having actual strokes.
So yeah, so it typically, I would say most commonly, trauma, one where you have like an actual direct compression over the nerve. It can also be secondary to some type of viral infection as well.
Yeah, my friend had it with Lyme disease.
With Lyme disease, yep. Typically the virus that's actually involved is a herpes simplex virus. So it can manifest from several different ways. That's crazy though. Thank you for sharing. Okay, so that's it for TMJ. We're going to quickly transition over to the pelvis. All right.
The pelvis. Do we have this one?
Can you see it?
We don't have
Can't
it.
see it. Hang on.
I was gonna say, 'cause like it pulls up the clues for the pelvis, just not the cross.
All right, it's visible.
There it is. Found it.
Okay, same thing. This lecture is not bad at all. We're just going to kind of quickly go through it. All right, so this is chapter 17 for your book. Okay, so first off, from bio 150, what bones make up the pelvic girdle? Sacrum, coccyx, two innominate bones. All right, what makes up an innominate bone?
She went through pubis.
Ilium, ischium, and pubis. Nice job. Okay, so your pelvic girdle, like Josh said, you have the sacrum, you have the coccyx, you have two innominate bones. Each innominate bone is made up of the ilium, ischium, and pubis. So these are all fused together, so it's still one unit, but those are the individual sections of it. Okay, so we have four big joints that we're going to talk through here. So we have bilateral sacroiliac joints. So that's this space right here, also known as your SI joints. Okay, your pubic symphysis, that's this one right here. And then we don't really, you can't see it on this one, but you have your lumbosacral joint. Okay, so basically the articulation between L5 and the sacrum. Okay, here is a review for your bony anatomy. If you guys need it from bio 150, if you need a little refresher, this is nice because it's color coded. So in the yellow, you can see the ilium, the ischium is in purple, and the pubis is in green. So just make sure you are comfortable with your bony landmarks. Okay, review them as needed. Okay, so in terms of the functions of your pelvic girdle, this is going to be really important. It has a lot of different jobs. Okay, mostly it's going to help to support the weight of the body and transmit forces between your spine and your legs. Okay, whether they're forces going up from the ground or down from the spine. It also helps to protect the pelvic viscera and form the bony portion of the pelvic canal, of the birth canal. Okay, so first big thing we're going to talk through here is called the true pelvis and the false pelvis. Okay, so up top here, they're labeled in this image. The top portion is the false pelvis, and then this inner portion here is the true pelvis. Okay, the false pelvis is also called the greater pelvis. False pelvis is also called the greater pelvis, and this is going to be the area that lies between the iliac crest and the pelvic inlet, which is this top red line right here. Okay, You can find the pelvic inlet by drawing a line between the sacral promontory, which is right here, and the superior portion of the pubic symphysis. Right, that is your pelvic inlet. So false pelvis sits between the iliac crest and the pelvic inlet. Okay, there are no organs in the false pelvis. Okay. Versus your true pelvis. The true pelvis is going to sit between the pelvic inlet. What were your landmarks for the pelvic inlet? Say it.
Pubic symphysis and the sacral promontory.
Sacral promontory and the superior portion of the pubic symphysis. Okay, so true pelvis sits between the pelvic inlet and the pelvic outlet. In order to find the pelvic outlet, you're going to draw a line between the coccyx and the inferior portion of the pubic symphysis. Okay, so everything that sits between those two lines is the true pelvis. Okay, true pelvis is going to contain your pelvic organs as well as form the birth canal. Okay, this one just shows a few differences between the male and the female pelvis. Okay, so when you're looking at these images, you can see that overall the female pelvis is going to be much wider. Okay, it has more of an oval-shaped superior opening as compared to the males, which is more of a heart shape. This portion right here, you can see that. In the female pelvis, overall, this entire cavity is going to be shorter in height, and it is going to be less of a funnel shape as compared to the males. The acetabulum and ischial tuberosities are going to be further apart. And then your pelvic arch, this highlighted portion down here, is going to be wider on the females compared to the males, where you can see it's more pointed. Okay, so for your joints, we're going to start first with the pubic symphysis. Okay, so this is a really easy area to palpate. Okay, it sits right in the midline of the body. This is basically where your pubic bone is. Okay, so this is going to be the junction, the actual articulation between the left and the right pubic bones. Okay, that forms your pubic symphysis. Okay, you do have a fibrocartilaginous disc that sits right in between those bones. Okay, so overall, this is going to be an amphiarthrobial joint, so we know that there's very little movement here. Okay, this does change during childbirth. Okay, so it will increase in its ability to be mobile in order to allow for the birth of the child. Okay, it is supported by two different ligaments. So you have the superior pubic ligament and the inferior pubic ligament. Okay, they literally just sit right on the top and the bottom of the joint. Okay, so superior pubic ligament is right here, and its job is basically just to stabilize the superior and anterior portion of the joint. Right? So it's going to connect between the left and the right pubic tubercles. Supports the superior and anterior portion of the joint. Versus the inferior pubic ligament, that sits right at the bottom of the joint, and it is going to connect your left and right inferior pubic rami. And in exact opposition, this is going to help stabilize the inferior portion of the joint. Okay? We also have your sacroiliac joints, your SI joints. Okay, so that's what this image is pointing to right here. This joint right here and right here. Okay, so it's going to be the articulation between the sacrum and the ilium. Okay? Its main job is basically just to transmit forces, okay, between the pelvic girdle and the spine. Okay? It is designed for a lot of stability. Okay? There is controversy to that in our field, but in general, nature of this joint is stability. Okay? Because this is a primary stabilizing structure, it has very heavy ligamental support. Okay? So we have a lot of ligaments to go through for this section. Okay, so we have 7 right here that we're gonna talk through. We're gonna go through each one of these. So we have the anterior sacroiliac joint, sacroiliac ligament, the interosseous sacroiliac ligament, the posterior sacroiliac ligament, which has 2 different portions. It has a short portion and a long portion. Sacrotuberous, sacrospinous, and iliolumbar ligaments. So all of those work together to help stabilize the sacroiliac joint. Okay, so starting first with your sacroiliac ligaments. Okay, we have an anterior, posterior, and interosseous here. So anterior sacroiliac ligament. If you look at this picture, you can see it right here. It's very broad. So this is going to sit on the anterior surface of the pelvis. Okay, it is going to run from the sacrum to the ilium, and it is going to hold together the anterior part of the joint. Okay, interosseous sacroiliac ligament. This is going to be a lot deeper, so it's your deepest ligament here. It's going to be the shortest and the strongest of the sacroiliac ligaments. It is going to connect the sacrum to the ilium. And then the posterior sacroiliac ligament. Okay, like we said, we have 2 different portions here. We have a short portion and a long portion. Okay, the short is going to run in between the ilium and the sacrum on the dorsal surface, and its job is to prevent forward motion of the sacrum. Okay, versus the long posterior sacroiliac ligament is going to run from the posterior superior iliac spine to the sacrum, and its job is to prevent downward sacral movement. Iliolumbar ligament, okay? Make sure you look at the names of these, they'll tell you where they go. Okay, so this is going to run from the transverse process of L5 to the iliac crest. Okay, so iliac crest to lumbar, lumbar being L5. Okay, this is going to help limit rotation of L5 on S1. Okay, it also helps to prevent anterior translation of L5 on S1. Okay, so it's important, again, a very important stabilizing ligament. Okay. All right, we also have sacrotuberous ligament and sacrospinous ligament. So your sacrotuberous ligament is going to be also a very strong ligament. It's going to be a little bit more triangular in shape, and it is going to run between your posterior superior iliac spine and the posterior inferior iliac spine, and then it's going to run down even further and hit all of these different areas. Okay, so it's going to connect on your sacrum, on the lateral surface of the sacrum, and then the coccyx as well. Okay, this is going to serve as an attachment point for the gluteus maximus. Okay, so that's one of your attachments there. In terms of its function, it is trying to prevent excessive forward rotation of the sacrum. Okay, this is easily injured with falls on the ischial tuberosity. Okay. And then your sacrospinous ligament, so this is going to sit deep to the sacrotuberous ligament. Okay. It's going to be a little bit more broad of a ligament in general. It's going to attach from the lower lateral sacrum and the coccyx to the spine of the ischium. Okay. Now, these 2 ligaments together are going to form the space where the sciatic nerve is going to pass through. Okay. So you can see that through here. The sciatic nerve will run right through these ligaments. Okay, sacrum motions. Okay, so at the sacrum, we have a sacral nutation and a sacral counternutation. Okay, nutation means sacral flexion. Okay. You are going to name these by the direction that the base is going. Okay, so sacral base moves anteriorly. That would be your sacral flexion or nutation. okay? This is going to occur with trunk flexion or hip extension. Okay, versus counter nutation. Counter nutation is sacral extension. Okay, so here your sacral base will move posterior and superior. That is going to occur with trunk extension or with hip flexion. Okay. All right, just a little bit on pathology and some of the different positions that you'll see of the pelvis that may or may not be pathological. Okay, so first, SI joint dysfunction. This can be a result of a lot of different things. Okay, it could be related to trauma, to poor posturing, poor body mechanics. Pregnancy is probably the big population that you will see this in general, muscular weakness, arthritis, etc. So this is a very highly debated pathology in our field, okay? Because there is so much ligamentous support for this joint, we know there's not a lot of movement. There is one way of thinking where a lot of people are like, you don't have enough movement at the SI joint to cause so much dysfunction, versus on the other end of the spectrum, you hear people all the time saying, oh, my SI joint is out, I need an adjustment, because they can feel that. So as we go through the next year, we'll give you guys a lot of information on the SI joint, so you have it as you go into practice, and then you can make your decisions on how you feel about it as you start practicing. Okay, but just know for now, these are some things that could potentially cause SI joint dysfunction. Okay, we also have your lumbosacral joint. Okay, so like I said earlier, this is going to be the articulation of L5 and the first sacral vertebrae. Okay, so this is still the same as the rest of the spine. You still have an intervertebral disc that sits here. These are going to be held together by the anterior and posterior longitudinal ligaments, which we will learn next week. Okay. The ligaments for now that you need to know is your iliolumbar ligament that we've already mentioned, that attaches from transverse process of L5 directly to the iliac crest. So it just runs straight horizontally. Okay. And then you also have the lumbosacral ligament that attaches from the transverse process of L5 and goes to the sacrum. One more angle here that I want to talk about is called the lumbosacral angle. Okay, so this basically is looking at how much lumbar lordosis somebody has. Okay, so this angle right here is a way to measure that. In order to draw this angle, the first line you draw is basically just going to be parallel to the ground. And then the other angle is going to be along the sacral base. Okay, so base of the sacrum is going straight up, and that angle that is created is what you would actually measure. Okay, so your optimal angle here, your norm for the lumbosacral angle is 30 degrees. Okay, as lumbar lordosis increases, you're going to end up with an increased angle, indicating an anterior pelvic tilt. Okay, versus a decreased angle, you're going more into a posterior pelvic tilt. Okay, everybody put your hands up. Like this. Okay? In this position, from your perspective, your fingers are your ASIS, your thumbs are your PSIS. Okay? So if we go into, so this is the normal position of your pelvis, those things should be equal. Okay, pubic symphysis right in the middle. We go into an anterior pelvic tilt, you drop your fingers forward. My ASIS is now lower than my PSIS. That's an anterior pelvic tilt. Okay, if we go backwards, my ASIS is now higher than my PSIS. That is a posterior pelvic tilt. Back to neutral, we have a lateral pelvic tilt. Okay, ASIS and PSIS on one side are going to be lower than the other. Okay, you also have rotation. Okay, so I could rotate forward like this, or I could rotate backward. So anterior pelvic rotation, posterior pelvic rotation. Okay, those are your pelvic motions. Okay, so it's important to understand what muscles are involved in those actions as well, okay? So, for example, if we take our anterior pelvic tilt, so from your hand position, ASIS is moving down, PSIS is moving up, okay? From here, you know in the front, your hip flexors are pulling the pelvis down, okay? So right here, hip flexors are pulling down into an anterior pelvic tilt. They could be tight, okay? So if those are tight and pulling down, that's gonna help tilt the pelvis forward, okay? Simultaneously, the trunk extensors in the back are going to be pulling up at the back of the pelvis, okay? So this is basically a force couple, okay, like we talked about in Unit 1. So this is what's happening at the muscular level in order to create your anterior pelvic tilt. Okay. Same thing with posterior pelvic tilt. So now if we go in the opposite direction, our pelvis is tilting posteriorly. Here, your trunk flexors are pulling up at the front of the pelvis, while your hip extensors are pulling down at the back of the pelvis. Okay. All right, we're not gonna dive super deep in here, but this is basically the same concept, just from a habitual posturing standpoint, okay? So if you are always sitting in an anterior pelvic tilt or a posterior pelvic tilt, it's kind of like the chicken and egg situation, right? Where the muscle's short and that's what causes the position, versus where you sitting in that position and that causes your muscles to become shorter, okay? Either way, when you have somebody that presents with an anterior pelvic tilt or a posterior pelvic tilt, you need to be able to hypothesize what muscles might be short and tight versus what might be elongated and weak, okay? And that's the purpose of this slide. So if you have an anterior pelvic tilt, we already said the hip flexors are pulling down and the trunk extensors are pulling up, so those muscles are likely going to be short and tight, okay? The muscle groups that directly oppose those is what is going to be long and weak, okay? So for an anterior pelvic tilt, the trunk flexors and hip extensors are likely going to be elongated. Okay? Does that make sense? At least enough for now to be able to study it? Okay. All right, we're almost done, guys. Hold with me just a couple minutes. Lateral pelvic tilt, okay, we already talked about that. This, you can do this in isolation, but the most important place you're gonna see this is with overground ambulation, okay? So when somebody goes into a single leg stance, without any muscle activation, gravity is naturally going to pull the unsupported side down, okay? So we have to actively utilize our muscles in order to maintain a stable pelvis, so you don't get this pelvic drop on the opposite side, okay? So, for example, if I'm right here, if I go into a left single leg stance, my pelvis is equal, okay? If I disengage my muscles, I'm gonna fall like this. Okay, that part makes sense. Okay, in order to keep it here, this is going to be my left side glute med, most specifically, that is contracting to maintain the stability of my pelvis. In addition, on my right side, my right quadratus lumborum, my right QL, is pulling up at my pelvis. Okay, so it's pulling up, glute med is pulling down, so I'm creating a force couple here in order to maintain the level of my pelvis. Okay, so if you see somebody who is walking and they have that pelvic drop, they most likely have weak glutes on the stance side.
That could be probably could be by scoliosis as well.
It could result in scoliosis, absolutely. And you can see that in this picture. When you get that drop on one side, it's naturally going to curve the spine. You're going to get a compensatory side bend with it as well. Okay? Hip hiking, that's basically the opposite. It's what I was just talking about, where your QL is pulling up. okay? You can also do that as a pit hike, which would turn into an exercise as well if somebody was weak there. Last one, pelvic rotation. We basically already did this, but just consider as you're walking, you're going to get this pelvic rotational motion as you advance your limbs. Okay? All right, that's it. Great job today. Again, send me your emails if you're less than a 75. Let me know if you have any questions. And if you did not do well on this exam, please go back and review the material. Okay, it is important. If there are concepts you do not understand, come see me and we can talk through them. Sound good? See you guys in practicals.